All right. This is a continuation of the Lake County Ambulance Service charting presentation. We had an interruption previously, and it's a nice break, so you've had about an hour on that first one, so we'll try and finish it up here. So we left off at the patient assessment area and using the power tools or the patient assessment tools. So I'm going to bring that back up again. So medical, every patient should have a complete physical exam, and it's either in the narrative, a complete exam, or using the medical assessment tool in the exam. Injury, also show you that. And then the last one I was going to show you is the burn. And again, understanding the rule of nines and how that all interacts is something that's a little trickier for me. So there's a nice little tool you can use here to help assess your burns. So for example, we have a patient who was loading boxes into his burn barrel on his farm. It turns out one of the empty boxes wasn't so empty and had some gunpowder in it. Had a big flash, kind of a little bit of an explosion, flash fire flared up. So along his chest, he has second degree burns lower, third degree burns upper. If you click on it, first we get second, there's your third degree. You click on it again, okay? And then he had his arms extended over. The front part of his arms only got second degree burns. And then you can click this circumferential tool, and his forearms also took a beating, and his hands. Okay. And if you'll notice over here on the back, it already made those circumferential. You can click it again to turn that off in case, we got the ears or the neck or whatever you wanted to add in there. And so then if you look back over here, he has got 28% total burns, 20 of which are third, 8 second. So it's a tool that you can use to help calculate burn area and to document burn assessments. Now, the burn assessment itself does not print out on the paper chart. So if you click on this, it exports it back over to your injury assessment. So it includes all the burn information over on the injury chart, which does print out on the patient care record when you print for the hospital. Okay. So moving right along, vitals in treatments area. So in here you have your activities, and there's a number of things that happen in here. So there's medications need to be entered here, procedures need to be entered here, vital signs, and if a paramedic is on board or a nurse is going to be doing documentation, the EKG interpretation goes in here. If an EMT crew, so BLS, both EMT crew, were to capture a 12 lead, we'll add that into the narrative, what the computer interpretation is, not entering it in the flow chart as a confirmed or as an interpreted EKG. That would go into the narrative. Word of caution, we use a lot of fancy electronic equipment. We import a number of things from our monitoring equipment. Be sure to review it to understand what it is that's bringing it in. If things that come in don't make sense, so for example, it runs a blood pressure when it's not connected to an arm, or we're bouncing down the road so bad it gets a 200 over 199 for a blood pressure, and you know that that's inaccurate because you were able to adjust it and stop, got a smooth road, took a blood pressure, comes out at 120 over 80. When you import those, clear out the junk. Look at the things that it's reporting, because I've seen a number of charts where we have these very wild changes in blood pressures. When looking at the narrative, looking at the patient, looking at how it's described, are obviously inaccurate. So clear that out. The actual bulk core data is still available into the machine, that's fine, but it clutters up the chart that gives an inaccurate picture of what was going on. There are certain events that happen. You can use even code markers. Those need to be adjusted. So that import of data is very handy at timestamping, at showing the flow, but it still needs to be edited for the final product that we publish. So let's talk real quickly. So you do the imports, you go back and edit them, but let's just talk about adding something right up front. So there's vital signs. You can click right here, it says add vitals, self-evident. You put in your blood pressure, your systolic and diastolic, your pulse, respirations. This again is one of those areas on the import that unless you're doing end-tidal CO2 monitoring, you do not have respirations. Take the time, be a professional and count the respirations. Enter those in here. That is a complete set of vital signs. Add your what your SpO2 reading is and what the qualifier. Are they on oxygen? If they're not, whatever. If it's room air, that's fine. Was the pulse regularly irregular, etc.? You can do that. Where did you take that? Was on the right arm, left arm? What was their position? Was their respiratory rate regular or irregular, etc.? Then that's the core piece. There are other pieces that in a number of cases for your initial set generally like to add this in. So were they alert, verbal, unresponsive? If you do a stroke scale, this is where you record that information. So sometimes maybe you just do the stroke scale. So click on here at the time that you did it, and that's the only thing you enter. So if that was done prior to your arrival, for example, first responders took a set of vital signs prior to our getting there, I generally do that, enter this time, and me doing it, even though rescue may have taken it, I'll enter the time I contacted the patient, what they gave me, but then indicate that it was taken prior to my arrival. The other ones in here, this is where you document your pain scale. So is it 0 to 10? Enter that number. At least a starting and an ending GCS should be included, and then any time that GCS changes, it should be included. So you notice you can't enter a number directly. There are a series of power tools, and in this case, we'll show you the GCS power tool that allows you to then go ahead and select, in this case, opens eyes spontaneously, oriented appropriate speech, etc., initial, not chemically sedated, etc. So plugs in, it gives you the value you need. If you want to be more specific on the pain, or maybe you didn't use a number scale, so there's a PQRST or a pain power tool. So this would be your OPQRST questions. What brought it on, or what does it feel like? Where you can do all sorts of things in there if you want to be more specific. Where is my severity? There we go. Severity was a 10, and you can actually type in something else that you want there. Okay. If you do a temperature, you can enter it in and how you took it. Blood glucose. So while we take it and we log it as a procedure, we've been entering that number in the comments section. That's a little difficult to find for the bulk of the providers that we might want to be looking at this. So when you take a blood glucose, there should also be a corresponding value that is entered as a vital sign. So if at 12:01 we took we did a procedure. We started an IV and we took a blood glucose off of that, and it came back at 113. We'll enter the 113 here. Maybe that's all we did at 12:01. So we'll enter that. That might be the only piece of vital sign we enter for this particular patient. Say save. There should be a corresponding procedure at 12:01 that shows that we did a blood glucose analysis. So the difference between the value and what the procedure. So this is where we record that value. If you want to enter it in the comments, it's fine as well. APGAR would only be on a delivery or on an imminent birth, etc. These trauma scores will adjust automatically based on age, level of GCS, and blood pressures, etc. So if you want to use the vital signs power tool to enter this is a really fast, easy way. So the heart rate was 100. It was regularly regular. The respirations were 24. Regular. Blood pressure was 110/60. And it was on their right arm. They were sitting when I took this one. Their SATs were 98% at room air. I don't want to worry about a cardiac rhythm or a pain scale at this point, so I'm just going to say OK, plugs all that information in, and I hit save. All right, so you can do all those sorts of things. Then if you want to add a medicine, same thing. There is a medication power tool if you want to use that, but let's just use one we typically do, or often, would be oxygen. So oxygen by nasal cannula. Great. So when I do that, it defaults to liters per minute in inhalation. That's how we deliver it. How much did we deliver? Let's call it 2. Were they better or not? In this case, unchanged. It was not prior to arrival. I'm doing it under a standing order. And there were no complications. I don't need to enter any comments. Save. Super. There's another one. So say you start an IV. So that would be a procedure of venous access. I'll show you how to do that. Okay. Venous access extremity. And size of equipment, we're going to use an 18 gauge. Oops, 18 gauge. And it's going to be, this is going to be under standing order. We did it in the left hand. We were successful. Here's where this might be something new for some of you. There is only one attempt. So we're going to record every time we puncture the skin as an attempt. So needle, we try and go through, either it's successful or it's not. If we try again, that is a new attempt, and that time reflects when we initiated or poked through the skin. For invasive airways or semi-invasive airways, king airway attempt, if we pass the king through the lips, past the teeth, that is considered an attempt, and that would either be successful or unsuccessful. Same thing for intubation. If we do laryngoscopy to take a peek, but we have not passed the tube, we're not going to count that as an attempt. We'll just document that in the narrative. Once the tip of the tube goes past the teeth and lips, that counts as an attempt, and we're either successful or unsuccessful. The problem with putting 3 or 4 attempts in, that doesn't let us know much on the time. Does that time mean when we started? Does that mean when we succeed? How long did it take us to attempt? So there is only one attempt at each procedure. It is either successful or unsuccessful. And then again, patient response is either improved, unchanged, improved, or they got worse. If there's complications, go ahead and indicate those. So we just did an IV, so we also then, in a lot of cases, have a medicine. So our medicine would be normal saline, and the dosage would be, there's 2 ways of entering this, and I'm okay with either one, but if you're going to do a rate, so let's do it as 150 milliliters, so we're going to do 150 milliliters an hour. That's great, because that's your dosing, and I know when you started, and I know when you ended. For a cross check, put in total in the comments. Total in, because you had them for half an hour, would be 75 milliliters or so. Okay, so it's kind of a cross check to make sure that's exactly how much we went in. Unchanged, no, it wasn't prior to arrival. All right, there's no, it's under standing order, and there weren't any complications. If you do it the other way around, let's say we put in 75 milliliters, then just put 75 milliliters, and intravenous, great. Total in, if you'd like to put the rate, you certainly can. You could put in TKO, but that dose is the total in. So if you actually, we need to have a cross check. If you have a rate, we also need to know the total amount of volume in, and that can be put in the comments. So my usual is I put the rate here if it's a maintenance line or on a pump or whatever. So 75 milliliters an hour, or 100 mils an hour, whatever it happens to be, and my total in here, so they have so we know that I actually did put in 50 milliliters total. Or if I do a bolus, so if we have somebody I want to do a fluid challenge with, then I'll actually put in. So I maybe want to do, it's 20 per kilo, so they're a 100 kilo guy, I want to put 2 liters of fluid in. I'm going to do that in 200 milliliter boluses, so it's going to be 200 milliliter. And I'm going to indicate here fluid challenge or bolus, something like that. Okay. All right. So now there's an even faster way to do that. We can do the IV power tool, and in this case, here's your choices. This venous access existing catheter is in the procedures list. You can pull it from the power tool or just in the procedures list. That would be the one you select when you're taking a transfer. Somebody already has an IV in place. We still need to note that they have an IV, but we didn't place it, so we can click that procedure. Otherwise, it's one of these. So we're going to start an IV. So venous extremity, 18, location, the hand left, condition of the site, that's after we get it up and running. There were no symptoms. Was there swelling? Certainly we can add that. Flushed easily, attempts was 1. Well, I was successful. Well, now that I was successful, it gives me the option to, oh yeah, and I put normal saline, and I put it at 150 milliliters an hour. Okay, done. So it puts both the procedure and, hold on a second here, there's the procedure and the medicine pasted in for me. Now, if I want to put my total, oh, excuse me. So we save that. Everything's done, okay? Okay. So other procedures that need to be entered in there. C-collar, so spinal mobilization, rigid collar. long backboards. If you are using the long backboard for spinal immobilization, there is a spinal immobilization procedure. If you're using it as a litter, it doesn't get entered as a procedure. You can just mention that in the narrative that you use the backboard as a litter to move the patient. Two procedures that I'd like to have entered in their definitions. So, cardiac monitor. When we pick cardiac monitor, that means that we are putting on electrodes to monitor the patient's electrical activity of their heart. So if I hit cardiac monitor, if that is it, we don't have a size, the location's just chest in general, so you can either leave that blank or not available. Okay, and then there's going to be one attempt, and were we successful? Well, yeah, if we're putting on a cardiac monitor, so this is the 4 electrodes to do standard EKG monitoring. Patients generally unchanged when we do that. It was not usually done prior to arrival. We're doing this under a guideline. Okay, if there were comments, whatever. Comments, fine. Again, either crew member can get credit for this. So if you're an EMT and you're working a BLS crew and you do put a cardiac monitor on to capture EKG rhythm, great. Log this as a procedure. There would not be a corresponding EKG interpretation added to this because EMTs are not allowed to actually interpret EKG. So save the procedure. So this is done once when we put on the electrodes to start monitoring. Any subsequent interpretations by the paramedic or nurse would then be added as an add EKG interpretation. So in this case, I put it on, or Mike put it on. Now at 12:09, I'm also, as the paramedic, going to interpret the EKG. I'm doing this off the EKG monitor, not the 12 lead. Paramedics, when you're making this, please try and pick one of the standard definitions. You can make a comment about it later, but for example, let's say we have a normal sinus rhythm with peaked T waves. Okay, so it's still sinus, but you notice peaked T waves. Whatever it happens to be, you can add in, but this here is a data element that lets us search a little bit better, gives us some better searchability. If you just type in a random or a generic, your own interpretation, it doesn't allow us to report that. If you find ectopy, great, go ahead and notice. So we had some crap there. I was looking at primarily lead 2 for this interpretation. This is my initial rhythm or spontaneous. These can be used in the event that we were to be delivering shock or pacing, but otherwise, those can be done as procedures as well. All right, so here's your interpretation. So there's the procedure, there's an interpretation. Now, if something changes, I can add a new interpretation. The next procedure, so add a procedure, would be this is the 12 lead EKG. So again, when we place the electrodes for EKG capture for 12 lead, we don't have a size, location would be chest or not available because we don't have the whole chest. There's one, you're either successful or you're not, but in this case, we're placing the leads, so we should be. Patients generally unchanged when we do that. It's a protocol or standing order. And either crew member can do this part because the procedure can be, the EKG placement can be done by anybody, paramedic or EMT, so we'll save that. Again, if when we capture the EKG, when we import, sometimes that will show as an import and it won't have an interpretation, but it will say 12 lead EKG or cardiac monitor. Be sure to go back and edit that. If, again, it's a paramedic crew, when you captured that, there should also be a corresponding EKG interpretation. If you do subsequent ones, add 12 lead EKG, grab your interpretation, do the best you can with what is available in the diagnostic stuff here, or what you think the main underlying rhythm is. So let's say it's a normal sinus rhythm and it's a 12 lead EKG, so we are looking at if you want to go generic like this, we can certainly show ischemia, but normal sinus rhythm with elevation in with, excuse me, ST, elevation in 2, 3, AVF, and depression in 1 AVR and in, excuse me, lead 1 AVR and V1. Something like that. You can certainly put the ectopy as it looks like it's inferior ischemia or inferior infarct. You got ST, however you want, EKG. In this case, it's a 12 lead EKG. Cause for change was it's spontaneous. However, okay. So hopefully that gives you enough of that. So if you've imported, make sure you edit that you reference stuff. If there's junk, clear it out. If there's vitals that have been imported, please take the time to edit those, add in the respiratory rate that was at the time. The other one is that I've seen a number of cases where patient contact was at 11:15, but the first set of vitals isn't until 11:45, and 11:45 happens to be the transport time. We should be getting a set of baseline vitals within the first couple of minutes of patient contact. So break out the old manual BP cuff and stethoscope, use your finger, get down on a pulse, take the time to do the care right, and then document that. Okay. All right. So any other questions on activities, give me a ring or an email and I'll let you know. Try and help you through that. Personal protective equipment is up to you if you want to enter that routinely, but definitely if you have an exposure, include that. If you want to indicate which guidelines you were following, although we jump from protocol to protocol depending on the patient, this may or may not be appropriate. If there is a cardiac arrest, this section of the form must be filled out. So it defaults to no. So just remember that if you do have an arrest, go ahead and fill that out. Okay. Now jumping to the narrative tab, there's a couple things in here. Your provider primary and provider secondary impression area. And this particular area is your diagnosis. And I know you've been told you can't diagnose. Well, yeah, you can. We may not call it that, but you do need to come up with what do you think is the problem. This is your primary thing that you think is wrong. So going back to my original example of the guy that we got dispatched for the seizure, but was complaining of his leg itching, but had a knife sticking out of his back. For this, it's not what they're worried about. This is what you're worried about. And in this particular case, provider primary impression is going to be traumatic injury. Now, unfortunately, because these are big general classifications and how we report stuff, traumatic injury is everything from a stub toe to a multiple gunshot wound that fell off a cliff. It all falls into the same thing. That's where we tell the story in the narrative. But in this case, traumatic injury is my biggest concern. My secondary concern at this point is either bleeding or pain or whatever my other chances are. I have some other ones in here. So I think there was a wound. Nope. Hemorrhage. That sounds like fine. Okay, maybe I have bleeding as a problem. Where did it go? All right, there's some other stuff in here. I have to go back through and look. Okay. Hypovolemia shock. Nope. So great. So just for this case, I'll call it pain. But the traumatic injury is my biggest issue. All right. You do sometimes you'll have a secondary impression, sometimes you won't. So this can be blank sometimes, it doesn't matter, but you do need to have a provider primary impression. There are from time to time, you may truly have somebody that's a provider impression of there's just nothing wrong with their hypochondriac, you can't figure it out. Even those patients often that are behavioral because they're just simply so worked up. This is an anxiety issue. And in this particular case, maybe it's, whatever, and it goes. So find that. There should be no other here. Excuse me, let me do that again. Occasionally. I mean, there might be something completely out there, but even then, plain other wouldn't cover. You can at least get it down to a body system. Somewhere in here, there may end up being, I believe it's one of the standard that there is no apparent illness or injury. However, that's pretty rare as well because there's some reason we came there. They're either too weak. Even if this was a nursing home discharge going back, there's a reason they're going by stretcher, and that could be just generalized weakness. So pick the one that's closest to it, and you can tell the story better. You do not have to have a second one unless there is a secondary impression, but this is your biggest problem, your working theory as to what's wrong with this patient. Patient transport and positioning. Generally, it's either we stair chair or was it the stretcher that got them to the ambulance. Sometimes they walk, and if they do, they do. Go ahead and do that. Most of the people we transport are semi-followers. Occasionally, they're plain pure supine. And then when we move them into the hospital, in most cases, we do the stretcher. So great. So like that. Safety equipment is not safety equipment used during the run, but at the time of their incident. So this would be if they're involved in an industrial accident, a car crash, were they wearing or using some sort of protective equipment? Go ahead and indicate that there. Also, In here would be if it's a vehicle collision, describe what there was on the vehicle. Was there steering wheel deformity? Was there a rollover, etc.? Where was the patient? Were they in row 1 through whatever? So if it's a large bus, it may have multiple rows. The bed of the pickup would be if it's a, so row 1, 2, probably be row 3. Some pickups would be row 2. Position of the patient, so were they on the driver's side or not? If they were the driver, great, select the driver, but otherwise it'd be the left, and they were non-driver, that kind of a thing. Other things about the vehicle. So if it's a vehicle crash, that's where they're. And then here, if you could get this, it'd be helpful. Were they better, worse, or about the same when we dropped them at the hospital? Later on, we'll be able to do some follow-up, and we can add to this chart later on in what the emergency department found, or maybe what the hospital course was, so we can build a complete picture, beginning to end, of how this patient did long-term. Was our diagnosis similar to what the ER thought it was? This is a little new for some of you. This is service-defined questions, and this is a way we're going to be trying to track how many calls are happening at any one time, where we're responding to calls from. There wasn't a place in the form that says, where did you start this call? So if I looked and said, why did it take you 30 miles to get to Lakeview Hospital? Well, you were actually coming back from St. Luke's. I wouldn't necessarily know that by looking at the chart. So this is your chance to do that. So let me describe these. Post assignment. So if you're the primary crew, that's your post assignment. You may not actually be there. You might be over at Silver, at Super One or whatever. But that's your role at the time of the call. What was your job at that time? Were you a primary or secondary crew? For example, Mike and I are usually the secondary crew during the day, so that would be my assignment. Or your Silver Bay. If you are in coverage at posting at Gooseberry, and so a call has gone out and now you've moved to the coverage point, this would then, so you're at coverage, now a call comes out for you to go on, and your assignment at that point now is Gooseberry coverage, and you were starting at Gooseberry parking lot, or wherever you happen to be, because again, let's say Silver Bay gets a call to the veterans home. The primary crew at Two Harbors gets in the truck, starts heading on up towards the Gooseberry DNR office. They're heading up on Betty's Pies, so they're filling out a posting report because they're doing internal coverage, and another call comes out in Silver Bay. So they would finish out, so their coverage chart would stop, so we could finish that one up, ending time. This ending time of the coverage chart would be the starting time for the new response. They were assigned Gooseberry coverage at the time of this incident. They were at County Road 3 and Highway as the actual starting location, and there was already one other incident happening at the same time. All right, at the time of page. If you have questions about that, let me know. Then your narrative. There should be an opening statement of a brief description of what you found when you got there. So many people would be dispatched for whatever. Found 33-year-old male, supine, A&O times 3. A&O times 3 with ABCs intact, etc., etc. I'm attaching and will post online the a narrative guide. So I'd sent out in an email with it, but I have access to that. So let me just summarize here. You should have an opening statement which includes age, gender, position, found, and where found, so and location. So 14-year-old male sitting on a bench, a 72-year-old female semi-reclining in a nursing home bed, 35-year-old female in emergency department bed, semi-foulers, whatever. And alerts and oriented or level of consciousness statement. So it can be as simple as patient alert and oriented times 3. It might be AVPU equals U. It can be unresponsive, whatever. and then an ABC statement. And for most of our patients, ABCs are intact. Our airway is patent, breathing is approximately 20 with no increase in effort, circulation, full bounding pulse. You can be as expressive or as least little as you need to. So somebody that maybe ABC is intact with rapid breathing. So everything immediately is okay, but you've noted that it's fairly rapid because generally we don't count at this point. So that's your opening statement. Then the next one would end up being a history of the present illness, or if you were thinking or talking about sample questions, this would be the events leading up to in your sample question. So history of the present illness, what brought us to being here today? 45-year-old male watching the All-Star game, really hates Derek Jeter, started to be feeling some chest pain, thought it was heartburn, took 2 bottles of Maalox. It didn't resolve after about 30 minutes. Patient's wife convinced him to call 911. We arrive, great. So now we got a picture of what led us up to being there. If it was a transfer, patient was admitted to hospital yesterday with a vague complaint of generalized weakness. Overnight or throughout the course of the hospital stay, patient has been now diagnosed with a new onset atrial fibrillation with corresponding with related hypotension and underlying developing pneumonia, whatever it happens to be. So build a picture as to what it is that we're doing there. And then in the case of a transfer, finish that out with patients now being transferred to St. Mary's Hospital for cardiology care, cardiology intervention or cardiology care not available at Lakeview Hospital, or orthopedics or trauma care or intensive care, whatever it happens to be, why they're being transferred. A generic higher level of care isn't as descriptive, and so more specifically, that helps the billing company, the biller, build a picture when we submit that to either insurance, Medicare, whoever it happens to be, as to why wasn't it the hospital they were in good enough, and why did we have to go to the other destination? So building that case, although we do have the physician statement, that makes it a lot better. We can also have it right there in the chart, so we don't have to go looking for it. Okay, so opening statement, age, gender, location, position, ANO times 3 or alert level of consciousness, an ABC statement, history of present illness, and then generally a chronological summary of the call. Do I need to know that John Fox was the driver while Mike Hatfield was the primary care provider? No, that's already somewhere else in the chart. So this can be as simple as physical exam was as noted. In this case, we were talking about a special attention. So we in back. I can't remember. Secured with dressing. You're going to have that already there. IV. You can just a brief summary. The specific details are already in the flow chart, but still build a picture of what it is you did, kind of in the order that you did. Transferred to cut V, 2-person lift to rig, transport, en route. You can do a en route pain complaint of reduced 2 out of 10, which you've already done in your vital signs anyway, but just to kind of build that picture. Whatever you're doing en route. Okay, if you have a significant finding, if you have something that you need to clarify, great. This is a perfect place to do that. I generally like to add in, so for my closing statement would be radio report prior to destination, transferred care to Cindy RN, because I already have it someplace else. I'll show you that in a second. Please take the time to make this organized. So What did you find? Why were you going there? What did you find when you initially got there? Then what led us up to being there? In all the circumstances, the patient said that they were walking from the bedroom to the bathroom, tripped and hit their knee, laid there for 2 hours until family came home. Family tried to lift him into the bed, wasn't able to, called 911. Then what did we do about it? So just a brief story summarizing. We don't need each blood glucose reading. We don't need each vital sign reading in the narrative section. If you have not done a physical exam, though, that is where the physical exam would go, would be in here. So had no complaints of headache, equal and reactive eyes, no JVD or tracheal deviation, chest denies chest pain, lung sounds were clear, abdomen was soft, non-tender ×4, pelvis was stable, no sign of loss of bladder or bowel, extremity CMS ×4, back, no complaints, etc. So you do a complete physical exam, and you'd have to express that in the narrative. All right. So when you're typing this out, don't forget this is like a word processor. So just because you remember it and you just type whatever you think, try and take and organize that into each paragraph means something. So your opening is what you saw when you got there. What brought us to being there? Here's the summary of the call, and here's the closing part of it. We transferred care. We did that kind of stuff. All right. Then moving on to signatures for right now, until you hear differently, we are getting both paper and electronic signatures. So moving on down, bring the computer in with you, get a signature from the patient. Best the best is the patient. If we can't, I'll tell you what we can do. So in this case, they agree for authorization of billing. They understand that privacy practices and how we can exchange them. We're not going to sell their information, but we can talk to doctors, nurses, and insurance companies. Waiver of liability, only check something if we're dealing with the waiver. In this particular case, we're not, so we either leave it blank or click on not applicable because we're not discussing or concerned about a waiver of liability. Patient should sign, John Fox. They signed today, and we'll get their name, and that will import in from the patient name. Otherwise, you have to type it in. Okay. All right. That's the usual way of doing it. Now, if they aren't able to, an authorized representative, so family member, a care provider, somebody that's their legal representative can do that. So again, they would check the same thing. In the case of a minor, we wouldn't enter any information there. Now the parent would. They agree that we can, they understand the rules on HIPAA, They understand the HIPAA consent. They're not waiving liability in this particular case unless this was a no load and will not applicable. And the authorization for billing if they're a family member that can do that. If you don't have a family member that's able to do that, if we are down to the patient's unconscious, we can't get them to sign, we would skip all that. We would go to here, and the authorized representative can be anybody that is a caregiver. So could be somebody out of the nursing home, could be somebody that provides services. It can actually be the nursing staff at the receiving hospital, if that's all that's available. Medicare will accept that. This is just a verification that we really did bring this patient to that particular area. Okay, so that's how you do that one. Give me a second here. Witness signature, generally we don't need unless the patient, we have, say for example, patient is refusing to go and also refuses to sign anything, is disagree or whatever. So if we run into that kind of a situation, then generally it would be that you would document that the patient refused, and that the witness signature is your partner, is a law enforcement officer, somebody else also verifying that the patient verbally refused and care and verbally refused to sign the patient. That's just another cross check. We don't need that very often. Your technician statement, and again, in almost all cases we need to do this, that you've provided the assessment and treatments for this patient. Additionally, if they are unable to sign, we would also want to indicate that here we're signing, and then we get the name, it'll pull in the primary care provider. This is another chance for you, if you hadn't changed those roles, you click it and it suddenly Mike pops up. I go, oh crap, Mike is still listed as the primary provider. I need to go change that so that it comes in. Indicate why, so this patient is unresponsive. whatever, profound. Again, we should be getting signatures. So if anything, even the crappiest of signatures is better if we can get the patient's actual signature. But if they truly can't, go ahead and enter it here. So please make an attempt. While right now not required in here for patient and receiving, please try and get into the habit of doing it. We have to have a yellow sheet, the paper copy, until further notice. We still need a paper copy of it. We can't do billing. And then the hospital receiving agent, so that the patient was transferred to their care, Cindy RN, okay. And in here for the name, first name is usually good enough for most cases, and then their title, okay. And then I click on that, although the time, not when they signed, but when did I transfer care? So it maybe took me 10 minutes to write the rest of this chart, and so I actually did it, I gave report at 12, and that's when I handed off care. So I want that to indicate when I actually exchanged patient care. Okay. Where that can come into play is, let's say we have our destination at the hospital time of 12:15. Well, maybe it takes us 15 minutes to get up to the room, and maybe it takes 15 minutes to find the nurse that was on break, and so we have a 30-minute turnaround time. So we still have them in our care for an additional half an hour. We should be taking care of and still monitoring some of those things. Once we transfer care, this should be that number there. Okay. So I was talking about the patients that we go the lift assist, or the I've fallen and I can't get up, I'm not sure if anything's wrong. We think something's wrong, maybe we don't think something's wrong. We give them our assessment, we recommend and offer transport, they refuse. We offer again, they refuse. We say, I can't really see, I don't have X-ray glasses, you could have something that's going to be very serious, you might even die. Nope, I understand that, I know it's today and where I'm at, etc. All right, well, we'd be happy to come back at any time. We clearly say all of that in the narrative, and then they sign I agree on the waiver of liability. They are going to refuse treatment transportation, and then they're also against medical advice. So we can do either one, request release or just AMA. But in this particular case, it's that they don't want to. If, say, somebody wanted to refuse a C-collar or refused an IV, this could be used to list that as well. But in most cases, let's just talk about transport. And the reason they don't is because they don't think that's necessary. Chief complaint's been resolved, whatever the choice is. What's their alternative plan? I'm going to stay home and keep an eye on it. And patient might be alone. In this particular case, the family is at home with this particular patient. And then run down the rest of this list. It's a little tricky because in here it says DDM on all of these, but down here it doesn't include it, but it's intended to be that way. So what this means is the patient or dedicated decision maker. So the person who has authority to refuse and sign this form. So in the case of a child, the parent has every legal right to refuse care. If that's the case, then in this particular incident, that's who we're talking about. So is the person signing this form oriented to person, place, and time? Yes. Oh, excuse me, not. So yes. Is it unimpaired? Yes, they're unimpaired. Competent? Yes. They know they can call back. Has recusal? Yes. Are they 18 or age? So the person signing, so here I know it literally says patient, but the person signing for this, yes. And was a BLS care only or no medical care? Yes. If this is no, or if there's not a no, really um, needs to then be a consultation with your doc. Are we okay to sign for them? So if we had to provide an advanced life support intervention before no loading, then this is a kind of a back check for us to go, oh shoot, I probably should talk to a doctor about that. The exceptions to this is going to be a known diabetic, known hypoglycemic, no other complaints that we've solved with D50 that is on insulin. If they're on oral hypoglycemics, that would require physician contact because there's something else wrong. But that would be the one exception in this particular case. So attach this AMA checklist to all patient refusals. Last little piece on here before we get too much farther is the valuables. Now it's not required, but we're going to probably start adding that in down the road. So if on a transport, you have, their wallet or their purse, if they have medications you brought with, indicate that they were left where. So at destination with the staff. So we put them on a helicopter. That would include that. If there's other things, so so on a transfer, so we have imaging, X-ray CD or CT CD disc or whatever, walker, cane, whatever it is that we have and where we left them. Okay, this is a great way to indicate that. Yep. So, oh, you guys lost my glasses. Nope. We had your glasses and your dentures along with your medications, wallet, and purse were left at the destination. Okay. So we're done with that except for our times. So let me go into times real quick before I go wrap it all up. There are a couple of other times that can show up here, but we do not know what those are. So we don't know when the original call came in for 911. We don't know when the dispatch center was aware of the call, but we do know when the unit was dispatched. We do know when we're en route. We are en route when the wheels on the ambulance are turning towards the destination. Our goal, we'll continue to work on getting that out the door time even better, but this needs to be accurate. Remember, things are time stamped. If you're not sure what they are, talk to dispatch, call them back up, get the times, but we need accurate information here. You arrive on scene when you're at the location. The exception to that would be is if you're told to stage in the area because of safety issues. For example, respond for injuries from an assault at 123 Anywhere Street, stage at the corner of First and Anywhere. When you arrive at First and Anywhere, enter that as your arrive scene. Then when you make patient contact, just make note of that time. The arrived patient is okay to be an estimate, but be a realistic estimate. Just because we got on scene at 12:40 doesn't mean we got to the patient at 12:41. It might have been still 12:40 or it might have been 12:43. Do your best to get a good accurate estimate on that. Going into the school or going into the hospital, we may have to be a while. If we go into the hospital and we arrive there at 12:40, we walk in, patient's in the ER, but they're not our patient yet. We haven't gotten a report. We haven't done anything. For 7-8 minutes, wait until we're now starting that interaction where we're getting a report on the patient that we're now starting to do interactions. That's your patient contact time. Okay. And then again, if you have a staging issue, go ahead and note that in the narrative. When you leave the scene, that is when you're now loaded in the ambulance with the patient heading towards the hospital or other destination. Go ahead and enter that time when you arrive. Again, this is a new one for some of you, but when we clear the hospital, be it in Duluth, Minneapolis, or here in town, we are in service there for this particular time. So, arrival Lakeview Hospital, okay, LCAS 3, arrival Lakeview Hospital, 12:41. So you drop the patient off, you give a report, you make your cot, you put everything ready to go, you load the cot back in, your bags are put back in. LCAS 3, clear Lakeview, returning Silver Bay. That time is now, okay, LCAS 3 returning, 12:57. Enter 12:57. The in-quarters time is used, not literally in quarters, although routinely it probably will be, is when we're no longer involved with this call. So say, for example, a routine kind of thing out of here in Two Harbors. It's 12:42, we're clear the hospital. Great. We go get some gas and we head back on up, or excuse me, we just head back on up here and we're backing in the garage. It's 12:45. LCAS 2, Lake County, LCAS 2, we're back in quarters. Back in quarters, 12:45. Great, I enter 12:45 in quarters. End of call. Or if we clear the hospital, now I need to go get fuel, and then we need to run down to the hardware store because I need to get a tool for something that we're doing maintenance on. The in-quarters time and the in-service time could be the same because I'm now done with this call. It's already finished. It's posted. Everything's done. I just now need to move on. Same thing can be coming back from St. Mary's in Duluth. You're in service when you clear St. Luke's, or excuse me, let's say St. Mary's. You clear St. Mary's, but by the time you get the county line, your chart's done, you've posted it, it's printed, everything's all complete, so you can actually put your in-quarters time at whatever that happens to be. So that number's a little bit more vague, but if we put it in literally as in quarters, if we say on the way back, get another run, on the way back, get another run, we finally get back to quarters at 5 tonight, it would look like if I put that 1700 in the first run, it looks like I'm on 3 runs at the same time, so we can't be doing that. The unit canceled time is only if we're canceled. If we get to the scene, we can't find a patient, that's not being canceled, that's just no patient found, we're now back in service, etc. Now, I said earlier that we don't try and trick the system by changing numbers. The only time that I would make an exception to that is when we're doing some no loads or some of those other kinds of things. So if we have a patient refusal, so we do help them up, they sit them on their bed, they will not go. So then so we arrive at the scene at 12:30, the patient refuses, it's 12:44. So we're clear the scene with a signature at 12:44. The destination would also be 12:44 because the destination was the scene because we're not going anywhere, and we're in service at 12:44. Similarly with the miles, if we do a no load, the destination is the same as the scene, so those miles make up. Otherwise, the computer gets confused. And anyway, if you run into trouble with that, let me know. All right, so we've talked about times, we've talked about those other things. Then before you post, if you look over here, there's a validation button. So in this case, the response disposition is missing. It will tell you what it's having some issues with, and so you can run through all those. And in this particular case, I'll click on it, and it will bring me to that particular tab. Great, I've cleared it. So what else is wrong? Date of birth is missing, so I'll click on date of birth. It's going to be 11/26/1967. Oh, great. So now something was wrong here. So 11/26/1967. Okay, great. Oh, it clears that out. My score gets better. Remember, you do not have to have a perfect score, but you should make an attempt at getting all this information. Oh, that's the other thing. All patients get at least 2 complete sets of vital signs. Okay. One set of vital signs doesn't tell us a whole lot except for that immediate instant. A trend, at least 2, gives you more information. So I forgot to add that in there. All right, so there you go. And when it's all time now, we go to post. And in this case, I'm just going to save the run. And let's try posting. All right, so I go to post. I still have some validity number issues. Now, in this particular case, social security number, unconscious or unresponsive, or patient gender is missing, whatever. And call number, that doesn't matter. Location type is missing. So in this particular case, canceled. What a description. Now, if so first name is missing, this isn't the good example, but for whatever, say this was the social security number rule, unresponsive, and that's the reason for all of that. I'll fill it in and it pulls it all the way through, okay? If it was blank, it'll paste that in there. And then just say, okay, I'm going to cancel that. I'm not going to post the run because this is a fake run. So please enter that. It is not required quite yet, but it will be soon to have an explanation. All right, a couple of other little things in here, some of the tools for those of you that are a little worried about pediatrics. If you enter a weight and an age and a gender while we're doing this, now many of us are not using this real time, but if I were to do this under demographic and go age, so let's say that this was 2013 and the patient's weight was 15 pounds and it's a female, okay, and then I go to my assessment or my vitals and treatments, activities, and remember your Breslow tape? Why is that not showing up? I got confused, so let me see this. So 15 pounds, 7-month female, all because I screwed it up under my assessment stuff, so medical. I need to change body type to infant, say okay, okay, clears out all my other stuff. And oh, because in here it had a weight still, so I have to fix that weight. So you have a 15-pound kid, and now you know it's a pediatric color pink. Brings up the pink, and there's all your Breslow tape information right there. Okay, so any of you guys want to sit down and play with this at any point, I can set up a test site. You can come into the office. I'm happy to run through it with you. But hopefully this has helped. If you want to give me some feedback on the delivery method, I'd really appreciate it. I think that's it. So with that being said, I am going to turn off my screen sharing. Hope you guys have a great rest of your day, and thanks for listening.